Hey friends, this episode of The Fellow on Call is not meant to be used for medical advice and is intended for educational purposes only. Patient information has been modified to ensure privacy. The views expressed in this episode do not necessarily reflect the views of our employers. Enjoy! Welcome to another episode of The Fellow on Call, the Hemong podcast. We're coming at you from Merlot University Medical Center. I'm Ronak.
I'm Vivek.
And I'm Dan.
In today's episode, we continue on our sickle cell disease journey, this time focusing on chronic disease management, also things that will largely be done in the outpatient setting, things that a lot of our listeners may not get to experience on a day-to-day basis, either through training or working in a hospital or other type of clinic setting, but this is stuff that you will see if you were to work in a sickle cell disease clinic.
Yeah, and it's really important to know what these drugs are because oftentimes you want to restart home medications, and it's probably good to just know what these medications do. And for any hematologists out there, there's a chance that you might come across some of these patients every once in a while. If they live really far away from a sickle cell center, you may have to manage some of this, or at least co-manage it. So it's really important that we go through this today.
And it used to be more or less straightforward. I mean, we had like one medication that folks would generally be on, but now things have kind of exploded. There's a lot more coming out, and so we'll kind of get into some of that today too.
That sounds good, guys. Let's roll that show. So at the time that we're recording, we are in the midst of Olympic season. Guys, how are we feeling, especially about Team USA?
I think it's looking good. Certainly the basketball side of things, it's looking great. It's one of the greatest teams that I can remember.
Dan, what about South Sudan? What are you thinking?
I was very impressed. They showed a lot of spirit. The exhibition game that we played, I think maybe things were a little overreaction there in the first half, but we got our stuff together.
I agree. We played our good friend Jokic, who's won, 3 MVPs now or something, and we totally dominated them. And at the end, Steph hitting the 3, it's like, this is embarrassing. Did we need to do that? But I think they wanted to.
Just a cherry on top, yeah.
But about this U.S. gymnastics team, both on the men's and women's side, though, guys, I mean, not only is it exciting to watch on TV, but all of my social media feeds are just about this right now. And honestly, I can't get enough of it. It's awesome.
Yeah, Simone Biles' redemption tour, she's just crushing it. And Jordan Childs, I mean, everybody on the U.S. women's gymnastics team are just amazing.
Absolutely incredible. Yeah, Simone Biles is the GOAT for sure.
It's really an exciting time. I'm really anxious to see how the rest of the Olympics plays out. And, if we are recording during the rest of the Olympic season, I am excited to continue this conversation for sure. But in the meantime, we should turn our attention to our ongoing discussion that we've been having about sickle cell disease. And, one of the things that I think we've been doing a good job about in this series is not only talking about those things that people will see in the acute setting, but also shedding some light on what it looks like to be in a sickle cell clinic and to take care of these patients in the outpatient setting, which is something that a lot of us don't get a lot of experience in unless you want to do sickle cell disease as your career or you're rotating through this clinic as part of fellowship or something like that. I think today we should talk a little bit about what chronic management of sickle cell disease looks like. We already had an episode about chronic complications, but this is going through, I think we should go through what sort of a routine visit looks like, how we counsel patients on medications, what therapies are even available and things of that sort. So we can maybe start this discussion with a case as we've been doing.
All right, so I've got a case for us. We have a 25-year-old male with hemoglobin SS disease, complicated by frequent veno-occlusive disease, pain crisis, 6 to 8 hospital admissions each year, and 4 prior episodes of acute chest requiring emergent exchange transfusion, who is presenting to us for routine follow-up in hematology clinic. He acknowledges that he previously didn't focus on managing a sickle cell disease, but his wife recently gave birth to their son, and he feels an urgent motivation to get control over his health to be there for his family. He's not currently on any disease-modifying therapy, but has previously been prescribed hydroxyurea. He wants to know if he can be restarted on this medication and how it works to help control his disease. So let's talk a little bit about hydroxyurea. It's something that you hear all the time. We use it sometimes to temporize our acute leukemic patients. But in sickle cell, for anyone that's taking care of one of these patients, they've likely seen this medication on their list. So how does this work and how did it come into use?
Hydroxyurea is one of our oldest tools in management of sickle cell disease. Prior to the discovery that it could be used in sickle cell, our only way to reduce the complications of chronic vaso-occlusion and hemolysis was to provide intermittent transfusions. And even then, it was often reserved for emergencies like stroke and acute chest. We still don't have a complete mechanistic understanding of all the different ways that hydroxyurea works, but the downstream effect is that fetal hemoglobin production is upregulated. And it's time for another one of our little famous fellow on call deep dives into history, a little history lesson here.
This time it's Dan. Dan, the man's a historian today.
Yeah, that's right. For once, taking over the mantle here from VBAC. By the late 1970s, it was pretty clear that hemoglobin F containing cells, so fetal hemoglobin containing red cells, had a longer survival in individuals with sickle cell disease compared to those containing sickle hemoglobin. And that individuals with a persistence of fetal hemoglobin, so like a higher fraction of fetal hemoglobin just naturally produced, had more mild disease phenotypes. And so that pointed to the possibility of increasing fetal hemoglobin expression as a potential therapy for sickle cell disease. And in the early 1980s, there were some basic science studies trying to understand the transition between fetal hemoglobin and adult hemoglobin. These were studies done in primates. And they identified alterations in DNA methylation and chromatin modification that seemed to increase hemoglobin F production. They were able to show that exposure to azacitidine, the same azacitidine that we use in treating leukemias and MDS, was able to increase hemoglobin F production in animal models. By the mid-1980s, scientists were able to demonstrate that this increase in hemoglobin F production happened in humans as well with exposure to azacitidine. However, this was and still is a full-blown chemotherapy agent that causes widespread DNA hypomethylation and doesn't really represent a viable option for long-term therapy in sickle cell disease. So around the same time, doubt was being raised about the mechanism for azacitidine increasing fetal hemoglobin, with the thought that it was actually induction of stress erythropoiesis because of the sort of cytostatic effects of hypomethylating agents that might be responsible for this observed increase in fetal hemoglobin expression. There were some more primate studies that showed that non-hypomethylating cytostatic agents, hydroxyurea in particular, produced a substantial increase in fetal hemoglobin levels. So in the early 90s, we had our first phase 1 trial showing that fetal hemoglobin levels were increased in sickle cell disease patients who were treated with hydroxyurea. And in 1995, we had the first RCT showing efficacy. Now, this was before the modern era of fancy trial name acronyms. So this was just called the Multicenter Study of Hydroxyurea in Sickle Cell Anemia. It enrolled 299 patients with 3 or more crises in the year prior to enrollment. They were randomized and 152 received hydroxyurea. The trial actually had to be stopped early due to significant efficacy of hydroxyurea. It showed a significant reduction in crises from 4.5 per year in the placebo group to 2.5 per year in the hydroxyurea group, and double the median time to first crisis, 3 months versus 1.5 months. Patients on hydroxyurea also had acute chest syndrome at about half the rate of those on placebo, and fewer underwent transfusion as well. Of note, treatment was at least temporarily stopped in almost all patients on hydroxyurea due to myelosuppression, which improved with about 2 weeks off treatment. So this really was the dose-limiting toxicity. And they also showed that no neoplastic disorders developed during treatment, although they had fairly short follow-up of only about 21 months. Ever since then, hydroxyurea has been the standard of care, so since the mid-90s, and that includes in the pediatric population. There are likely some more effects of hydroxyurea related to immunosuppression and the sort of counteracting effect that has on some of the pro-inflammatory effects of sickle cell disease, and maybe even some vasodilatory effects related to direct nitric oxide release from the breakdown of hydroxyurea intracellularly, and that probably counteracts some of the nitric oxide scavenging related to chronic hemolysis. So definitely multiple mechanisms. It's an active area of research, but it was clear from the mid-90s onward that Hydrea was a great drug in sickle cell disease.
This is such a fascinating story, and that was a really good review of that. And I honestly didn't know that until you just talked about it, that it was very logical. You know, how do we increase this fetal hemoglobin? And it's crazy that azacitidine was the original molecule that was used. That's absolutely wild. And I'm glad now that we're at where we are today. So, Ronak, when you're considering starting a patient on Hydrea or hydroxyurea, how do you know what dose to start them on? You know, what labs are you checking? We talked about myelosuppression. Can you walk us through the things to look out for in these patients?
Yeah, absolutely. And also, Dan, I want to say, I didn't even know that there was a history for hydroxyurea that was that extensive. And I never even thought to check whether there was an RCT for it. I sort of just assumed that it was just something people just did. But
something we do, right?
Yeah, it's just, I'm glad to know that there's evidence-based medicine happening even for something whose mechanism we don't really understand. But Vivek, to your question about what we do if we want to start somebody on treatment, the first thing we obviously want to know is to check a CBC with differential and reticulocyte count. Just get a set of baseline labs for our patients. You also want to check things like B12, folate, and iron studies. And this is because hydrea can cause a macrocytosis. And in fact, the way that you can tell whether or not a patient is taking their hydrea is that you're actually looking for a macrocytosis. And so you want to make sure that there aren't any underlying nutritional deficiencies that could be masking the outcome or things that are correctable before we start somebody on new therapy. So we also want to get a baseline pre-treatment hemoglobin F level, and this also gives us an idea of what the fetal hemoglobin concentration is. Pregnancy tests are also important for any patient that could potentially be pregnant because of the teratogenic effects of hydrea. So when we start a patient on hydrea, assuming that they have normal renal function, we do want to start with a dose of about 15 to 20 milligrams per kilogram per day, and we round this based on the size of the capsules that are available. So if the kidney function is abnormal, though, we typically start about half that dose, so roughly 7.5 mg per kilogram per day. We then titrate the dose to the therapeutic effect, but understand, as we discussed already, that myelosuppression is going to be that major dose-limiting toxicity. So essentially, the way that people recommend doing this is that you increase the dose every 8 weeks by 5 milligrams per kilogram per day until one of the following maxima are reached: 35 milligrams per kilogram per day total dosing, or 2,500 milligrams per day total dosing, or they develop hematologic toxicities, and we'll list some of these toxicities in our show notes. And we're also monitoring because if there are signs of myelosuppression, we're going to have to adjust the medication or hold it completely. And so again, this is another point to highlight that if you're starting a patient on a new medication, you need to have frequent follow-ups to make sure that patients are tolerating the medication okay, and that we are appropriately titrating the medication to give our patients the maximum benefit.
Yeah, I think this is really important, and we'll list some guidelines in there, things like if the ANC drops below 1,000 or the platelets below 80K, you really hold that hydrea until the counts recover. So there are guidelines. It's always good to look these up, and we'll definitely include them on our website. Check it out. Check out our show notes, as we always tell you guys to do, because we spend a lot of time putting some of the details in there, so it's easy to just kind of find on the go. So sounds like myelosuppression's a big thing for hydrea, but what else are we counseling our patients on, right? There are other side effects of this drug. So Dan, what else are you telling your patients?
The main things to watch out for, other than the myelosuppression, are some GI side effects, things like nausea, reduced appetite. So definitely keep an eye on folks' weight while they're on this treatment, and some cutaneous side effects. Leg ulcers are kind of the one that you'll hear about the most, although we're kind of starting to question whether or not this is truly a hydroxyurea effect. We also know that leg ulcers happen with sickle cell disease in and of itself, so not fully clear that hydroxyurea is what's causing that, but it's still something where if you do see development of leg ulcers, often the recommendation is to either dial down or hold the hydrea altogether.
Yeah, I think those are really important things because we need to counsel our patients on, it's nice to say that, hey, this is going to make you feel a lot better, less pain crises, but it comes with other things. And we have to be really cautious about that dose. And the GI side effects are real. And so that's a really important dose-limiting toxicity to also consider in these patients. Another thing that a lot of our sickle cell patients ask us, and it's a very important thing to talk about, particularly in these adult patients who might be younger, they might be in their 20s, 25s, things like that. How does this impact fertility? Because that's a question that we get a lot. And you might get this question when you're just seeing the patient in the hospital. So how would you counsel the patient on fertility?
That's such an important question, something that we collectively in hematology oncology probably don't talk a lot about, but it is something. So in men, there is a reversible impact on spermatogenesis. So we typically recommend patients hold their therapy at least for 3 months prior to attempting to conceive. In women, we ask them to hold therapy prior to conception, but there's also some evidence that hydrea may reduce ovarian reserve with long-term treatment, but that is an active area of research. The evidence is somewhat mixed about how hydrea affects fetal health and development, and some studies show an increased risk of miscarriage or stillbirth with continuation, but there's no evidence of increased risk of congenital abnormalities in humans. The studies in animal models do show evidence for teratogenicity in some cases, so the decision of whether or not to hold during pregnancy should be individualized and largely will vary from center to center. At Rouleau, we generally do hold therapy during pregnancy, but you can consider continuing in patients with severe disease phenotypes who have shown strong evidence that they are benefiting from therapy while being on it.
I think that's really important. And, one other thing I just want to mention really quickly after that fertility talk is this idea of cancer. We kind of alluded to it a little bit of Dan saying, hey, there's a short follow-up, but we didn't see that. So what about the carcinogenesis? And there was this thought that chronic exposure could be carcinogenic. Much of the data was derived from older studies where the drug was used to suppress blood counts in myeloproliferative neoplasms, which already have a propensity to transform into an acute leukemia. So that really confounded this effect. And there's numerous observational cohort studies that have looked at long-term treatment in sickle cell disease and have found no evidence of increased rates of cancer or any of these hematologic malignancies with increased hydroxyurea use. So it's another thing that's important to counsel our patients on, that this idea that you're going to develop a malignancy if you take the hydroxyurea, it's just not as accurate in our sickle cell disease population. And there's a lot of research that's been done to that, and I'm glad that we have that answer because of all of the good effects that we've talked about, the pain crises, the reducing acute chest. We talked about last week, it might help pulmonary hypertension, right? There's so many downstream important effects that hydroxyurea has, stroke risk as well. So can't forget about those things. So now we have our patient and he's saying, hey, look, it's 2024. There's got to be all these new drugs out there. I've heard about all these things. I've heard about Oxybrita, some of the, they're using a bunch of brand names and you're probably scratching your head thinking, I've never heard of this drug. What is this? And Dari, you're like, I'm not quite sure which one this is. There are so many of these new drugs. So I turn the question to you guys. What are some of the recent advancements in sickle cell disease for disease-modifying therapy other than this blockbuster of hydroxyurea?
I want these drugs to work. I really do. I would love it. I was so excited when in the late 2010s, I was hearing about all of these new drugs that were in the pipeline and almost ready for prime time, sort of this big explosion of options since hydroxyurea was basically all we had since the mid 90s. But I do want to just talk about the evidence behind a few of these. So first one to come along was in 2017. That was the L-glutamine, or Ndari, was the first approval of a new drug in sickle cell disease since hydroxyurea. So from 1995 to 2017. And there's been a long history studying this amino acid as a potential sickle cell therapy dating back to the 1970s. And although evidence at the time was mixed at best that L-glutamine, and that's just the specific enantiomer of glutamine that they're testing, there was mixed evidence that it had any meaningful effect on red cell sickling. There were at least some theoretical considerations regarding the role of L-glutamine on NADH synthesis, which should provide some protective effects against oxidative damage, which was thought to be a big deal in sickling and sickle cell disease. So there was a phase 2 trial in 2014 that did not show any significant decrease in vaso-occlusive crises through 48 weeks of follow-up. And a phase 3 trial was performed as a follow-up to that. It was finally published in New England Journal of Medicine 2018. The approval actually came prior to the publication of that article. They presented, I think, 4 or 5 abstracts at conferences, and that data had been used in the approval. But so 2018, the paper finally comes out, and it was a study involving 230 patients who had 2 or more vaso-occlusive crises during the year prior to enrollment, and they were randomized 2-to-1 to L-glutamine versus placebo. Over 48 weeks of follow-up, the median vaso-occlusive crises, they had 3 in the L-glutamine group and 4 in the placebo group, with a similar trend in hospitalizations, 2 in the L-glutamine group and 3 in the placebo group. There was an increased time to first crisis with the L-glutamine group, a median time of 84 days versus 54 days. So that's a sizable difference. And there were high rates of discontinuation in both groups. So about 36% of the L-glutamine group ended up dropping out and 24% of the placebo group. The medication is administered in a powder to be dissolved in liquid. And although it's just an amino acid, it is technically on patent still, and it's pharmaceutical grade L-glutamine. So it's extraordinarily expensive for what it is. It's $18,000 to $27,000 a year at time of recording, depending on what dose people are on. So suffice to say, very expensive drug, lots of dropout in terms of, I guess, folks just found it either difficult to take or tolerated it poorly. And the effect size is very small, if it's there at all. So certainly not as exciting as I thought it was going to be when I first heard about it.
And, the key thing with these studies is that these patients should be on maximal tolerated doses of hydroxyurea, right? And so we're talking the sicker patients, right? The patients who are struggling more, where this drug is being trialed for. There's still unanswered questions. What if you did it earlier, right? There's still some unanswered questions in this as an earlier line of therapy. And at least for now, we were hoping for that blockbuster improvement, but like in our cancers, we try to march it up earlier, and it's going to be exciting to see that as we talk about each of these drugs. So, Rodak, I want to throw it to you. In 2019, we had another drug approved by the FDA. It was called crizanlizumab. Can you tell us a little bit about that?
Yeah, so crizanlizumab, or the brand name Adekvio, is a antibody targeting P-selectin, which is that adhesion molecule that you may remember from biochemistry that's thought to play an important role in mediating interactions between sickled cells and the vascular endothelium. And the idea is that basically you're blocking this interaction with this antibody, so therefore we develop less vaso-occlusion related to sickle cell disease. So this is an IV medication administered on days 1 and day 15 per treatment cycle, and this is every 28 days. And since this is a new monoclonal antibody therapy, it's also expensive. We're talking $85,000 to $113,000 per year, depending on the dose that's used. So now we are officially in the era where there are fancy names for studies. So there were 2 key trials to remember for crizanlizumab, the SUSTAIN trial and the STAND trials. In the SUSTAIN trial, there were 198 patients with 2 or more vaso-occlusive crises per year that were enrolled, and they were randomized 1-to-1 placebo to crizanlizumab at 2.5 milligram per kilogram dose and a crizanlizumab dose at 5 milligrams per kilogram. And the drug was given over the course of the year. So the median crises per year were 1.63 with the high-dose crizanlizumab versus 2.98 with placebo, and the median time to first crisis was longer. So essentially, it appeared, based on the SUSTAIN trial, that starting patients on crizanlizumab is going to improve the time to first crisis and the number of crises per year, which are great, again, for patients who may be struggling already on top of maximally tolerated doses of hydroxyurea. The STAND trial is the other trial that I mentioned. It is still ongoing, but we do have some interim analysis data that's available. So here we're comparing 2 higher doses of crizanlizumab, 5 milligrams per kilogram versus 7.5 milligrams per kilogram. So this is prelim data, but it's not looking good so far. The mean number of vaso-occlusive crises per year were 4.5 in the low dose, 3.1 in the high dose, and 3.7 in the placebo. And the median time to first vaso-occlusive crises was 3.6 months in the low dose, 6.2 in the high dose, and 6.2 in the placebo. The outcome that I find most striking is that the percentage of patients who are free of vaso-occlusive crises requiring hospitalizations. In the first year of treatment, 29.8% in the low-dose group, 37.3% in the high-dose group, and 40% in the placebo group. I mean, these are very high numbers, and to be honest, I'm curious to see what their inclusion criteria was for having these patients enrolled in the study. This is just a very high number, but again, as we mentioned, really not promising results based on the initial data that's come out.
And I think to the point that you're making too, we need to know how many of these patients continued to take the drug. How many dropped out early? Was it side effects? And one of the big things, the most frequent adverse events that we see with crizanlizumab are joint pains, diarrhea, vomiting, and infusion reactions that can include things like chest pain and itching. So we have our patients who are already struggling, and it can be hard to tolerate this. They're already so connected with the healthcare system. Coming in for these infusions once a month can also be a drain just on the patient, on their sanity of trying to avoid being hospitalized, avoid being a patient. So it's really interesting. And like you said, those are higher numbers. So it's promising, but we still have to see some of these results. And I really think that updated results from the STAND trial will really give us a lot more insight into the efficacy and how to use this drug. So back to our patient, hydroxyurea is the best starting point for him in terms of disease-modifying therapy. But the patient's father also has sickle cell disease, and the patient mentions that he started a new medication called voxelotor after developing leg ulcers. He notes that the drug has a very cool name, and he was pretty curious, what is this voxelotor? What's this oxybrida business? How does this drug work?
Completely agree. It does have a very cool name. It sounds like it would just get in there and like chop down the sickle cell disease like the voxelotor is on the case. The brand name Oxbryta I think is actually much less cool than voxelotor, but I don't design these things. I don't come up with these names. The drug works by binding to hemoglobin and keeping it in the oxygenated conformation. So remember, there's that conformational change that happens when oxygen binds to hemoglobin. So this keeps it in that oxygenated conformation. We know that sickle hemoglobin can only polymerize when it's in the deoxygenated conformation. So the idea was that maybe keeping it in this oxygenated conformation will reduce the potential for red cell sickling. The drug was studied in the HOPE trial, which is a decent-sized trial, 449 patients who had between 1 and 10 vaso-occlusive crises in the year prior to enrollment. And again, the patients were randomized here 1:1:1. They either received voxelotor 1500, 900, or placebo. And the study period was 72 weeks long. The outcomes they looked at included not only the incidence of vaso-occlusive crises, but also change in hemoglobin and other biochemical markers for hemolysis. The vaso-occlusive crisis data was pretty unimpressive. The median number of vaso-occlusive crises per year was 2.5 for the high dose, 3 for the low dose, and 3.1 in the placebo group with overlapping confidence intervals. So no statistically significant difference between those groups. They did see significant improvements in the markers for chronic hemolysis with voxelotor therapy, and a median change in the baseline hemoglobin of about 1.3 grams per deciliter in the high dose group, about 0.7 grams per deciliter in the low dose group, and no change in the placebo group, as you would expect. So it really seems like the best use case for this drug in particular is in patients who have issues with symptomatic anemia. And it seems like the best use case for this agent is in patients who have issues with symptomatic anemia that is not felt to be related to another underlying disease. So basically, symptomatic anemia that is primarily related to sickle cell. Remember that a lot of folks will have CKD, and so maybe they also have some EPO-responsive anemia as well. But if it's not that, and we just need to raise their hemoglobin, voxelotor might represent a good option there. There was also a post-hoc analysis from the HOPE trial, and it suggests that voxelotor may help with leg ulcer pain and healing. So this is also now considered an indication for starting treatment. But we don't have a specific RCT that's just kind of looking through the data from the HOPE trial and seeing that there might have been some signal there for that.
That's great. And it's really good to go through this data to understand what each of these drugs are doing for our patients, right? And this voxelotor medication, also known as Oxbryta, is increasing hemoglobin. And that's huge. It's huge when we think about symptomatic anemia, when we think about the burden of transfusions that some of these patients might receive, right? It could spare them transfusions in some cases. So it's very important pharmacologic therapy that we have now approved. So our patient was convinced. He got started on Hydrea. He knew it was the best disease-modifying therapy, and we also counseled him on some non-pharmacologic therapies as well. And, a couple of things just to briefly summarize. Important thing, maintain a normal sleep schedule, encourage adequate hydration, balanced nutrition. All of these are critically important, and I wish we had a comprehensive center that had nutritionists and other specialists to help these patients. Therapy is really important. We think about mental health, the social determinants of health for these patients, giving them resources, connecting them with people who might be going through similar things, support groups. All of these are really critical things because things like depression and anxiety can exacerbate and cause a pain crisis. Things like poor sleep can do that. Dehydration, nutritional deficiencies, these are things that are modifiable that we can really help with. Lastly, when we think about avoidance of damaging respiratory exposures, we think about tobacco smoke, inhaling other industrial chemicals, things like that. We always want to counsel our patients about avoiding those things. So before we wrap up today, I want to throw it back to Ronak to talk about one more thing. Let's say that the patient we had with sickle cell, he's on Hydrea, but he had recurrent gallstones, and now he met with a surgeon who says, hey, we need to take your gallbladder out. I think it's going to make you feel a lot better, reduce your pain. How do we manage perioperative transfusions for our patients with sickle cell disease?
So as everybody probably knows, there is certainly an increased risk of perioperative complications because of the underlying sickle cell disease. But just because someone has sickle cell disease doesn't mean that they can't get any procedures. We typically recommend simple transfusions up to 10 grams per deciliter to try and improve that oxygen delivery through the physiologically stressful induction of anesthesia and the actual operation. And it's important to remember that because transfusions aren't exactly benign procedures, We have to worry about transfusional iron overload, alloimmunization, the volume overload, hemolytic transfusion reactions, all of which are chronic complications that patients with sickle cell disease are already going to be facing from a lifetime of this disease. There was a study that was done to see if preoperative transfusion practices were even beneficial, and that was called the TAPS trial. So 67 patients with hemoglobin SS or hemoglobin S beta 0 were randomized to preoperative transfusion 10 days prior to surgery or no preoperative transfusion. And in fact, the study was stopped early because the interim analysis showed that 39% of patients in the control arm had clinically important complications, whereas only 15% in the transfusion arm did. A few things to note: patients with the baseline hemoglobin of less than 6.5 were excluded from the trial, so someone with a baseline hemoglobin in the low 6s or high 5s may not need to get all the way up to 10 to have a benefit from this therapy. And patients with a higher baseline hemoglobin of around 9 or greater were actually given partial exchange transfusions to get their hemoglobin S below 60%. And patients with high baseline hemoglobin should be considered for exchange on a case-by-case basis based on these data. So besides preoperative transfusions, we do recommend that the team uses things like IV fluids to maintain hydration throughout the perioperative and postoperative period, provide oxygen therapy to keep their sats over 95%, and that incentive spirometer that we talked about in the last episode also is really important in this situation. Postoperative pain management is also critical because, as we know now, pain itself can also be a precipitant for a vaso-occlusive crisis. So being very judicious, if you have a pain service at your facility, getting them involved to make sure that we're doing everything that we can to keep these patients' pain under control.
Yeah, I thought that was a really good recap. I'm really glad that you went over that. It's really important to talk about how do we transfuse our patients in this perioperative period. It's important for all of our listeners to know general anesthesia is a big deal for our sickle cell patients. Getting their hemoglobin up to 10 is important. If they have a very high baseline hemoglobin, it's important to talk to the sickle cell team and really talk to somebody with expertise in that particular setting. I'm glad that we went through that data. So I thought we had a great discussion today, guys. We went through all of the therapies, hydroxyurea, that big blockbuster drug that we've talked about before, and then we went through some of these new therapies. So that's all I can think of for today. What are your guys' thoughts?
Yeah, at the end of the day, hydroxyurea is still the mainstay of our chronic therapy. The dose-limiting toxicity is going to be myelosuppression, so watching the counts is important, and the adherence-limiting toxicity is going to be GI side effects, so just making sure you're counseling your patients and working with them to optimize that. We do have some newer drugs out these days, but the evidence is a little bit mixed, and oftentimes it's something you're reaching for when hydrea is not enough to control patient symptoms on their own, or they otherwise are not tolerating hydrea. Lifestyle optimizations are critical, so making sure people's sleep, hydration, nutrition, mental health, all that stuff is optimized, and encouraging physical activity within the limits of any physical limitations that they might have. Lastly, perioperative management. We know, like you just said, general anesthesia is a dangerous time for anybody, and especially in sickle cell disease. So working closely with the sickle cell team to plan perioperative care, including strategies like preoperative transfusion, trying to reduce that sickle cell hemoglobin fraction with simple or exchange transfusion, depending on the case, is going to be super important.
I couldn't have said that better myself. I've got nothing to add to that, Dan. Well, guys, I agree. I think that wraps up another fantastic episode of the Fellow on Call. So until next time, we'll see you all later.
See you later.
Peace.